My name is Verena Hackel. I am a physio, rehab engineer and lecturer based in Vienna, but most importantly, I'm here today as an ally for my friends suffering with long COVID and ME/CFS. I will be the moderator for this block of sessions. I'm pleased to introduce our first speaker, Professor Dr. Carmen Scheibenbogen. She's the head of Immunodeficiency Outpatient Clinic at the Charité Berlin, Germany. She will present on ME/CFS as part of the post-COVID spectrum. Welcome, Professor Scheibenbogen.
To my background, I'm a hemato-oncologist and clinical immunologist, and I'm working on ME/CFS for the last 15 years. I'm going to talk about ME/CFS as part of post-COVID, then coming to pathomechanisms, and at the end to clinical trials. Here are my disclosures shown. And to give you a brief overview what ME/CFS is, and I think we got already a very shaking impression just now by the video. It's a disease where this exertional intolerance is central and accompanied by many other symptoms. So most patients are severely ill. This disease is triggered by various infections. Now SARS-CoV-2 is the most frequent one. And there are several clinical findings, which I'm going to show you during my talk briefly. So in summer 2020, when the first patients contacted us, having persistent symptoms, we have initiated an observational trial. And as we are ME/CFS specialists, we were especially interested if ME/CFS is triggered by COVID and if the disease looks similar to ECFS we have known from other triggers. So we included in this trial patients suffering from moderate to severe fatigue and exertional intolerance, both very frequent symptoms in post-COVID. And what we learned from this trial, where we included 42 patients, 2/3 were female, they were on average 39 years old, and they were on average 6 to 8 months post-infection, all had COVID in 2020. What we've learned is shown here on the right side. So half of these patients fulfilled the diagnostic criteria for ME/CFS according to the Canadian consensus criteria. However, half of the patients did not fulfill the criteria. And the main reason why not fulfilling the Canadian criteria was because PEM was not so severe and did not last until the next day. And also in a subset, brain fog was only minor. Regarding other symptoms, which are typical, like headache, muscle pain, sleep disturbance, we saw no big difference. However, the sensitivity to light and noise was much more pronounced in the ME/CFS cohort too. And here on the left side, looking at disease severity, so all patients had fatigue assessed by the Gelder Fatigue Questionnaire. Here in the middle are the post-COVID ME/CFS patients with quite severe fatigue, very similar to the non-COVID ME/CFS. Those not fulfilling the ME/CFS criteria had less fatigue, and their functional ability was also better here, assessed by the Bell scale compared to the ME/CFS sufferers. In a follow-up study we published also, we had analyzed more than 100 patients, very similar distribution, epidemiological data, and the disease characteristics. And what we see here on the right side are the symptoms, pain, the ability to perform daily activity, and autonomic dysfunction symptoms like orthostatic intolerance and others. And every blue dot is a patient suffering from ME/CFS, and we see that during the time from month 6 to month 20, there was almost no improvement in the cohort, and the same was true for the severity of pain, which was similar, and the autonomic dysfunction. In contrast to the red dots, these are the non-ME/CFS patients, and we see that although many of them were still sick too, but they continuously improved. So within these studies, we collected a lot of samples and we performed a lot of biomarker studies. And I'm going to show you in the next minutes some important findings, I think, which are very meaningful. So we did a lot of analysis in blood. We also studied endothelial function, and we also did muscle biopsies. And coming to the serum markers, here we see as most striking finding early in disease at month 6, elevated interleukin-8 in many of these patients. That is similar in those fulfilling the ECFS criteria and those not. We see that after 12 months, IL-8 dropped in many of these patients. So, and another striking finding is that many patients have diminished phosphate, and we think this is a marker of mitochondrial dysfunction. This got much better in the non-ME/CFS cohort after 12 months, but not so clear in the ME/CFS cohort. We performed a comprehensive analysis of serum proteins by proteome, and to sum up, the most relevant finding is, so we see ongoing inflammation, coagulation markers, we see activation of platelets in both cohorts. These were samples taking between month 6 to month 12. We were also very much interested in endothelial markers, so we analyzed here on the left side the endothelial function by the reaction of the vessel diameter to ischemia. And what we see is that the dilation of the vessels is impaired in a subset of both ME/CFS and non-ME/CFS post-COVID patients. And these are young patients with no known risk factors for vascular diseases. Here is the healthy control group with normal endothelial dysfunction. And in line with this, we have evidence that we have diminished perfusion of tissue by increase of endothelin-1, which is a marker for this. The levels in serum you see here for the ME/CFS patients and the post-COVID patients, and here are the levels of the control groups. We did another very comprehensive analysis of endothelial markers. Just mention the most important findings. Again, we found interleukin-8 elevated, and interestingly, we found several molecules involved in nitric oxide mediated dilation, which provides us with evidence that this important pathway of endothelial dilation is impaired in these patients. Interestingly, these post-COVID patients also showed in vitro angiogenesis, which was not found in the ME/CFS cohort. In contrast, the ME/CFS patients had elevated autoantibodies against endothelial cells. The muscle biopsy studies were performed in a total of 11 patients, including ME/CFS and non-ME/CFS patients. And here the most relevant findings were inflammation, not severe, but still some evidence for inflammation. And we found changes in the vessels again. So we found thicker capillary basement membranes and somehow lower numbers of capillaries in the muscles. And the last finding I would like to share with you is our study on the G protein-coupled receptor autoantibodies. We are especially interested in those targeting vasoregulatory receptors, and we have been interested in these antibodies for a while. We know that they are elevated in a subset of ME/CFS and post-COVID patients. We have evidence that their function is actually impaired in ME/CFS and post-COVID patients. So these are special antibodies, so we do all have them, they usually stimulate the receptor in healthy people, and this function is not no longer adequate in patients based on our in vitro studies. And there is evidence that the higher the level of these antibodies are, the more symptoms the patients have, and also more alterations in central MRI studies. And just to share one finding from these studies in the post-COVID patients, we see that the higher the antibody levels are, the more fatigue the patients suffer from, and the more problems they have with the Raynaud phenomenon, we call it. So the fingers are not properly provided with oxygen and easily turn blue, red. And interestingly, these correlations we do only see in the subset suffering from ME/CFS, but not those not fulfilling the ME/CFS criteria. So based on the findings from our studies and several other research groups, we have now a quite good understanding of the pathomechanism of ME/CFS. Central is the diminished perfusion of capillary, which aggravates upon exertion and can well explain symptoms of brain fog, headache, but also muscle pain, weakness, and the post-exertional malaise. What in the muscle happens is that due to the insufficient oxygen supply, the mitochondria cannot produce adequate energy, and therefore the ion channels do not get sufficient energy as well, resulting in overload with protons, natrium, and calcium. And this is very dangerous because this is toxic to mitochondria. And actually, this mitochondrial damage and also muscle damage has been shown in several recent studies. And I'm really looking forward to the talk from Rob Wüst in a few minutes, who will hopefully go to show his data. The causes for these hypoperfusion are probably more complex again. And I listed several findings. We know that inflammation plays a role, autonomic dysfunction, endothelial dysfunction, but also impaired red blood cell deformability and low preload. And central finding are also these autoantibodies to G protein coupled receptors. And we also have a hypothesis already why only a subset of the post-COVID patients develops ME/CFS. We think that early in the disease, we have inflammation of the vessels, of the capillaries in all patients. And we see improvement both clinically, but also of the endothelial biomarkers in the patients not developing ME/CFS over time. In contrast, in the ME/CFS patients, we think that this inflammatory phenotype develops into a more mitochondrial and muscular problem, and this perpetuates the endothelial dysfunction due to production of reactive oxygen species. And potential risk factors to develop ME/CFS, we think, are those autoantibodies to G protein coupled receptors, but we know others like collagen diseases, Ehlers-Danlos, for example, and we know that there are also some genetic variants. So coming in the last 2 minutes to clinical trials, based on these findings, we target these mechanisms, and we are very lucky that we got funding in Germany from the Ministry for Research, and with this funding, we built up a clinical trial platform in which we combine research with clinical trials. So of course, we need a regulatory platform. It's quite complicated nowadays to perform clinical trials. We have a biomarker platform where we look into all these biomarkers. Several of them I just mentioned. We do have a diagnostic platform focusing especially on vascular analysis and of MRI of the brain and functional study of the brain. And we started with 2 trials of immunoabsorptions to get rid of autoantibodies. I'm going to show you some first data right now. We also have a trial in those patients where we have evidence for inflammation and severe neurocognitive impairment with methylprednisolone, that's a steroid, which is very effective centrally too. We have a trial using a drug from Bayer, vericiguat, which is a drug which can improve endothelial dysfunction and perfusion. That's already licensed for heart insufficiency. And we also do a trial with hyperbaric oxygen therapy, which is a very interesting technique also to improve perfusion, to build new capillaries, and to ameliorate inflammation. And in preparation are currently 3 more trials. One is on depletion of autoantibody producing B cells using an autoantibody targeting CD19. To give you some brief overview of the immunoabsorption, that's a technique by which you separate the blood cells by centrifugation. That's an apheresis technique, and immunoglobulin will then be removed by a specific column. This is very efficient, so you can decrease all immunoglobulins by 90%, performing this 5 times. We did such studies already several years ago in post-infectious ME/CFS. These were only small studies with little funding, but what we learned already is that we saw rapid symptom improvement in 7 of these 10 patients, and an ongoing improvement at least in some of these patients, although this is a treatment with which we do not expect actually long-term improvement, because we do not get rid of the autoantibody producing B cells, at least not by direct targeting. So we did a very similar studies in those developing ME/CFS post-COVID. Inclusion criteria were also elevated beta-2 adrenergic receptor autoantibodies, and again, we treated for 5 days. We included 20 patients in the studies. The interim analysis is already published, and I show you some data now from the response of these patients. Here on the top, you see the assessment of the physical function by a questionnaire. 100 means healthy, 0 means severely impaired. The patients had on average 25 before treatment, so they were quite sick and impaired. And we saw in 14 patients an improvement. This was our primary response marker, and this was very impressive in several patients. So 60 means that you are back in life. Here are the 6 non-responder, no change in this questionnaire. Very similar improvement of pain. So the higher here the bar goes up, the less pain. And again, we see good improvement in the responders, not in the non-responders. And I also want to show you the results from the post-exertion malaise questionnaire. Here we see in the responders less frequent post-exertion malaise, and we see also less severe post-exertion malaise. And very interesting also, the orthostatic intolerance got better here. For example, the orthostatic symptoms much improved in these patients. And as you see here, symptoms improvement lasted for approximately 3 up to 6 months, but thereafter most patients get sick again. So this is definitely a treatment we need to combine with drugs which can efficiently target these autoantibody producing B cells. And we, in addition, did numerous biomarker studies. Interestingly, we found some B cell alterations in those responding to immunoabsorption, which gives us great hope that this might be a biomarker for those responding to autoantibody targeting therapies. And we also do have already some markers for endothelial dysfunction, which are very clear, so they may also be developed as diagnostic markers. Information about this clinical trial platform is found on this website, and I just want to mention that many more clinical trials are ongoing worldwide, also targeting autoantibodies. So BC007 is an interesting trial, or Fc receptor blocker like efgartigimod, and I think we will see results from these trials already this year. And with this, I come to my summary. So ME/CFS is a severe and chronic form of post-COVID syndrome. We have evidence for early inflammation, endothelial dysfunction, and hypoperfusion. We have evidence for muscle damage and mitochondriopathy, together with several other studies. We have evidence for a role of G protein-coupled receptor autoantibodies. This has also been shown by several other groups in the meantime. Treatment studies are ongoing, but we need more and more rapid trials, and this is to acknowledge my great team and collaborators, and of course those funding our trials, and the patient groups who have supported us in performing these trials. Thank you very much, and now I'm happy to take questions.
Yeah, thank you very much, Professor Scheibenbogen. I'm going to take over from Verena. I'm moderating the session. So we have a couple of questions from the audience. So we would like to stay within time, so let's maybe do one or two questions. The most upvoted question is addressing an issue saying that the most severely affected cannot participate in the clinical trials and the studies. And how does science deal with that? How are we going to address this issue?
Yeah, that's an important issue, because the severely ill often cannot leave house, and they wouldn't tolerate such treatments, of course. So we need to develop special care for these patients. We need really to have physicians to go home to their homes and perform adequate diagnosis, and then try several treatments we do have already, also probably some off-label therapies, and that is actually a part of our care program. We have applied now for funding, and if we get the fundings, we will start with this project too.
Okay, thank you so much. So the question also elaborated on the issue that these people cannot really participate in clinical trials. Is there anything planned, like having them in hospital while running the clinical trial, or how is this handled in general?
Well, at the moment, I wouldn't dare to give them experimental drugs as long as we do not know which possible side effects we face. So the plan is that we go home to see these patients to make a good diagnosis. If necessary, we have a special opportunity to have inpatient diagnosis in a separate room with special procedures to make this possible, and first of all try to get the disease better by simple measures like supporting vascular function, improving sleep, treating pain, and probably trying off-label drugs like mestinon or LDA or LDN.
Okay, thank you very much. So going to the next question. People ask, what are the hopes for BC007? How does it look like in the moment?
Well, there was a larger phase 2 trial. This is completed now, and we eagerly await the results from these trials. And as you may have seen, I'm a member of the advisory board, and what I know is that the data will be available hopefully in October this year.
Thank you very much. So we're coming to one last question. People asking how many % of long haulers probably get ME/CFS. Do you have a number?
Yeah, that's a question which is frequently asked. We have no data from population-based epidemiology, but we can estimate that approximately, I think 20% is a realistic estimate. I have to add this depends also on the diagnostic criteria you use. In the US, mostly the IOM criteria are used, and these are broader, so more patients are captured than the Canadian criteria.
Okay, wonderful. So thank you very much for your time. The Q&A has ended now. Professor Scheibenbogen, thank you so much for making time to speak to us today.
Yeah, was a pleasure.
Very much. Thank you very much.
Bye.
Goodbye.
Mhm.